Histologic findings correlate well with the endoscopic appearance of clinical course of ulcerative colitis. The process is limited to the mucosa and superficial submucosa, with deeper layers unaffected except in pulmonary disease. Two major histologic features suggest chronicity and help distinguish ulcerative colitis from infectious or acute self-limited colitis. First, the cryptic architecture of the colon is distorted. Crypts may be beefed and reduced in number, often with the gap between the crypt bases and the muscularis mucosa. Second, some patients have basal plasma cells and multiple basal lymphoid aggregates. Mucosal vascular congestion with edema and focal hemorrhage and inflammatory cell infiltrate of neutrophils, lymphocytes, plasma cells, and macrophages may be present. The neutrophils invade the epithelium, usually in crypts, giving the rise of cryptitis and ultimately to crypt abscesses. Ileal changes in patients with black wash ileitis include villous atrophy and crypt regeneration with increased inflammation, increased neutrophil and mononuclear inflammation in the lamina propria, and patchy cryptitis and crypt abscesses. The major symptoms of ulcerative colitis are diarrhea, rectal bleeding, tenesmus, passage of mucus, and crampy abdominal pain. The severity of symptoms correlate with the extent of disease. Although ulcerative colitis can be present acutely, symptoms usually have been present for weeks to months. Occasionally, diarrhea and bleeding are also intermittent and mild, and the patient does not seek medical attention. Patients with proctitis usually press fresh blood or blood-stained mucus, either mixed with the stool or streaked onto the surface of a normal or hard stool. They also have tenesmus or urgency with a feeling of incomplete evacuation, but rarely have abdominal pain. With proctitis or proctosigmoiditis, proximal transient flows, which may account for the constipation commonly seen in patients with a distal disease. When the disease extends beyond the rectum, blood is usually mixed with the stool or grossly bloody diarrhea may be noted. Colonic motility is altered by inflammation with a rapid transit through the inflamed intestine. When the disease is severe, patient passes a liquid stool containing blood, pus, or fecal matter. Diarrhea is often nocturnal and postprandial. Although severe pain is not a prominent symptom, some patients with active disease may experience lower abdominal discomfort or mild central abdominal cramping. Severe cramping and abdominal pain can occur with severe attacks of the disease. Other symptoms in moderate to severe disease include anorexia, nausea, vomiting, fever, or weight loss. Physical signs of proctitis include the tender anal canal and the blood on rectal examination. With more extensive disease, patients have tenderness to palpation directly over the colon. Patients with a toxic colitis have severe pain and bleeding, and those with the megacolon have hepatic tympany. Both may have signs of peritonitis if a perforation has occurred. Active disease can be associated with the rise in acute phase reactants as C-reactive protein, platelet count, and erythrocyte sedimentation rate, and decrease in hemoglobin. Fecal lactoferrin and glycoprotein present in activated neutrophils is highly sensitive and specific marker for detecting intestinal inflammation. Fecal chylioprotectin is present in neutrophils and monocytes, and levels correlate well with histological inflammation, predict relapses, and detect pouchitis. Both fecal lactoferrin and chylioprotectin are becoming an integral part of inflammatory bowel disease management and are used frequently throughout active inflammation versus symptom of irritable bowel or bacterial overgrowth. In severely ill patients, the serum albumin level will fall rather quickly. Leukocytosis may be present, but it's not a specific indicator of disease activity. Proctitis or proctosigmoiditis rarely cause a rise of C-reactive protein. Diagnosis relies on the patient's history, clinical symptoms, negative stool examination for bacteria, Clostridium difficile toxin, and ova and parasites. sigmoidoscopic appearance, and histology of rectal or colonic biopsy specimens. Sigmoidoscopy is used to assess the disease activity and is usually performed before treatment. If the patient is not having an acute flare, colonoscopy is used to assess disease extent and activity. Endoscopically, mild disease is characterized by erythema, decreased vascular pattern, and mild friability. Moderate disease is characterized by marked edema, absent vascular pattern, friability and erosions, and severe disease by spontaneous bleeding and ulceration. Histological features change more slowly than clinical features, but also be used to grade disease activity. Crohn's disease was the first described in 1932 by three doctors, Baruch Crohn, Leon Ginsberg, and Gordon D. Oppenheimer. At the time, any disease in the small intestine was thought to be intestinal tuberculosis. Crohn can affect any portion of the gastrointestinal tract from mouth to anus and causes three patterns of involvement: inflammatory disease, strictures, and fistulas. This disease consists of segmental involvement by a non-specific granulomatous inflammatory process. The most important pathological feature of the Crohn's disease is that it's transmural, involving all layers of the bowel, not just the mucosa and submucosa, which is characteristic of ulcerative colitis. Furthermore, Crohn's disease is discontinuous with skip areas interspersed with between two or more involved areas. Late in the disease, the mucosa develops a cobblestone appearance, which results from deep longitudinal ulceration interlaced with intervening normal mucosa. Diarrhea, cramping, and abdominal pain are common symptoms of the Crohn's disease in all the above locations, except for the gastroduodenal regions, in which anorexia, nausea, and vomiting are more common. Rectal sparing is typical for the constant feature of the Crohn's disease. However, anorectal complications are common. Much less commonly, Crohn's disease involves the more proximal parts of the GI tract, including the mouth, trunk, esophagus, stomach, and duodenum. The incidence of the gallstones and kidney stones is increased in Crohn's disease because of malabsorption of fat and the bile salts. Gallstones are formed because of increased cholesterol concentration in the bile, which is caused by reduced bile salt pool. On the picture on this slide, you can see cobblestone change in the mucosa of the terminal ileum in the patient with the Crohn's disease. Crohn's disease can affect any part of GI, as we already talked, and unlike ulcerative colitis, which is almost always involved the rectum is often spared in Crohn's disease. Crohn's is segmental with the skip areas in the midst of diseased intestine. Perirectal fistulas, fissures, abscesses, and stenosis are present in one certain patient with Crohn, particularly with those with colonic involvement. Rarely may also involve the liver and the pancreas. Unlike ulcerative colitis, Crohn is a transmural process. Endoscopic aphthous or small superficial ulcerations characterize mild disease course. In the more active disease, the late ulceration fuse longitudinally and transversely to demarcate islands of the mucosa that frequently are histologically normal. This cobblestone appearance is characteristic of the Crohn, both endoscopically and by barium radiography. As in ulcerative colitis, pseudopolyps can form in the Crohn too. Active Crohn is characterized by focal inflammation and formation of the fistula tracts, which resolve by fibrosis and stricturing of the bowel. The bowel wall thickens and becomes narrowed by fibrotic leading to chronic recurrent bowel obstruction. Projections of the thickness mesentery encase the bowel, and serosal and mesenteric inflammation promotes adhesions and fistula formation. The earliest lesions are aphthoid ulceration and focal crypt abscesses with loose aggregation of the macrophages, which form non-caseating granulomas present on the picture here. Here is the granuloma. Here is granuloma. You can clearly see this. Here it is too. Here too. Here it is too. In all layers of the bowel wall, these granulomas are present, and they are characteristic feature of the Crohn's. Less commonly found in mucosal biopsies than on surgical resection specimen. Other histologic features of the Crohn include submucosal and subserosal lymphoid aggregates, particularly away from areas of ulceration, gross and microscopic skip areas, and transmural inflammation that is accompanied by fissures that penetrate deeply into the bowel wall and sometimes form fistulous tract and local abscesses. So at Crohn usually present as acute or chronic bowel inflammations. Inflammatory process involves toward one or two patterns of the disease: a fibrostenotic obstructing pattern or a penetrating fistulous pattern, each with different treatments and prognosis. The site of disease influences the clinical manifestation. Because the most common site of inflammation is the terminal ileum, the usual presentation of ileal colitis in the chronic history of the recurrent is a chronic history of the recurrent episodes of the right lower quadrant and diarrhea. Sometimes in its initial presentation mimics acute appendicitis with pronounced right lower quadrant pain, palpable mass, fever, and leukocytosis. Pain is usually colicky. It proceeds and relieved by defecation. A low-grade fever is usually noted. High sparkling fever suggests intra-abdominal abscess formation. Weight loss is common and develops in consequence of the diarrhea, anorexia, and fear of eating. The inflammatory mass may be palpated in the right lower quadrant of the abdomen is composed of inflamed bowel. In duration of the mesentery and enlarged abdominal lymph nodes. Extension of the mass can cause obstruction of the right ureter and or blood inflammation, manifested by dysuria and fever. The string sign of the barium studies results from a severely narrowed loop of the bowel, which makes the lumen resemble a frayed cotton string. It's caused by incomplete filling of the lumen as a result of edema, irritability, and spasm associated with inflammation and ulceration. The sign may have been seen in both non-stenotic and stenotic phases of the disease. Bowel obstruction may take several forms in the early stages of the disease: bowel wall edema and spasm, pursued intermittent obstruction, obstructive manifestation, and increasing symptoms of postprandial pain. Over several years, persistent inflammation gradually progresses to fibrostenotic narrowing and stricture. Diarrhea will decrease and will be replaced by chronic bowel obstruction. Acute episodes of obstruction occur as well, precipitated by bowel inflammation and spasm, or sometimes by impaction of undigested food and medication. Other episodes usually result with intravenous fluid and gastric decompression. Severe inflammation of the ileocecal region may lead to localized wall thinning with microperforation and fistula formation to the adjacent bowel, the skin, or the urinary bladder, or to an abscess cavity in the mesentery. In case of jejunal ileitis, excessive inflammatory disease is associated with the loss of digestive and absorptive surfaces, resulting in malabsorption and styria. Nutritional deficiency can also result from poor intake and entry-closis of the protein and other nutrients. Intestinal malabsorption can cause anemia, hypocalcemia, hypomagnesemia, coagulopathy, and hyperoxaluria with nephrontiasis in patients with an intact colon. Many patients need to take oral and often intravenous iron. Vertebral fractures are caused by a combination of vitamin D deficiency, hypocalcemia, and prolonged glucocorticoid use. Pellagra from niacin deficiency can occur in extensive small bowel disease, and absorption of the vitamin B12 can lead to megaloblastic anemia and neurological symptoms. Other important nutrients to measure and replete if low of folate and vitamin A, E, and K. Level of minerals such as zinc, selenium, copper, and magnesium are often low in patients with extensive small bowel inflammation or resection, and these should be repleted as well. Most patients should take a diet and multivitamin, calcium, and vitamin D supplements. Diarrhea is characteristic of active disease, and its causes include bacterial overgrowth and obstructive stasis or fistulization, bile acid malabsorption due to a diseased or resected terminal ileum, and intestinal inflammation with decreased water absorption and increased secretion of electrolytes. Patient with colitis present with low-grade fevers, malaise, diarrhea, cramp, abdominal pain, and sometimes hematochezia. Gross bleeding is not as common as in patients with ulcerative colitis and appears in about 1/2 of the patients with exclusively colonic disease. Laboratory study results are generally inspecific but may be helpful in supporting the diagnosis and managing the disease. Serologic studies are sometimes used to facilitate differentiation of Crohn's disease from ulcerative colitis or inflammatory bowel disease of undetermined type. Laboratory abnormalities may include elevated extracellular limitation rate and C-reactive protein. Its most severe disease findings include hypoalbuminemia, anemia, and leukocytosis. Electrolyte analysis can help determine the patient level of hydration and renal function. Fecal calcipoprotein and lactoferrin levels have been used for distinguishing inflammatory bowel disease from irritable bowel syndrome, which is the diagnosis of exclusion as its non-organic pathology, assess whether Crohn is active, and to detect post-operative recurrence of Crohn. Stool samples should be tested for the presence of white blood cells, called blood-routing pathogens, ovoparasites, and Clostridium difficile toxin. Capsule endoscopy is sensitive for early mucosal inflammation, but it can only detect mucosal changes, whereas MRI and intestinal ultrasonography are able to reveal transmural inflammation as well as identify complications. Ultrasonography, CT and MRI can determine pre-treatment and post-treatment disease activity or identify disease complication. There are 2 serological tests that are currently used in efforts to differentiate ulcerative from Crohn's disease. Antibodies to the yeast Saccharomyces cerevisiae are found more commonly in Crohn's disease than in ulcerative colitis, whereas perinuclear anti-neutrophilic cytoplasmatic antibody and myeloperoxidase antigen is found more commonly in ulcerative than in Crohn. The World Gastroenterology Organization indicates that ulcerative colitis is more likely when the test results are positively for anti-neutral cytoplasmatic antibody and negative for the yeast Saccharomyces cerevisiae antibodies to the yeast. Additional serologic markers such as Escherichia coli and OMPC can be found in more than 50 patients of Crohn cases and only a small percentage of ulcerative colitis cases. Pseudomonas fluorescens may be found in more than 50% of the Crohn and only 10% of the ulcerative. Flagellin-like antigen is associated independently with the small bowel intestine penetrating and fibrous disease. These tests further increase sensitivity and diagnostic value. Endoscopic features of the Crohn include rectal sparing, aphthous ulceration, fistulas, and skip lesions. Colonoscopy examination, biopsy of the mass lesion or strictures, and biopsy of the terminal ileum. Upper endoscopy is useful in diagnosing gastroduodenal involvement in patients with upper tract symptoms. Ileal or colonic strictures may be dilated with balance introduced through the colonoscope. Strictures less than 4 centimeters in length and those at anastomotic sites respond better to endoscopic dilation. The perforation rate is high as 10%. More endoscopies dilate only fibrotic strictures and not those associated with the active inflammation. Whereas capsules direct visualization of entire small bowel mucosa, the diagnostic yield of detected lesions suggestive of active Crohn's is higher with colonoscopy than OCT or magnetic resonance, interrographic, or small bowel studies. Plain radiography OCT scanning of the abdomen can be used to assess the bowel obstruction. These studies can also be used to assess the pelvis for the presence of any intra-abdominal abscesses. In Crohn, early radiographic findings in the small bowel include thickening folds and ulceration. Common staining from the longitudinal and transverse ulceration most frequently involves the small bowel. In more advanced disease, strictures, fistula, inflammatory masses, and abscesses may be detected. The earliest macroscopic findings of colonic Crohn are actus ulcers. These small ulcers are often multiple, separated by normal intervening mucosa. As the disease progresses, actus ulcers become large, deeper, and occasionally connected to the one another, forming longitudinal stellate, serpiginous, and luminal ulcers. On the picture here, you can see actually stricturing of small bowel in patients with the Crohn. Extra-intestinal manifestation of inflammatory bowel disease can be present as dermatologic ones. It can be erythema nodosum, which occurs in up to 15% of the patients with Crohn and 10% of the ulcerative colitis. Attacks usually correlate with bowel activity. Skin lesions develop after the onset of the bowel symptom, and the patient frequently have concomitant active peripheral arthritis. The lesion of erythema, hot, red, tender nodules measuring 1 to 5 cm in diameter and found on the anterior surface of the lower legs, ankles, calves, thighs, and arms. Therapy is directed toward the underlying bowel case. Pyoderma gangrenosum is seen up to 20% of patients with ulcerative and less common in Crohn. It's usually associated with severe disease. Lesions are commonly found on the dorsal surface of the feet and legs, but may occur on the arm, chest, stoma, and even the face. Pyoderma usually begins as pustule and then spreads concentrically and rapidly into the dermal skin. Lesions then ulcerate with biolustrous edges surrounded by a margin of erythema. Central then contain necrotic tissue with blood and exudates. Lesion may be single or multiple and grow as large as 30 centimeters. Other dermatological manifestations include pyoderma vegetans seen on the picture. Here is pyoderma vegetans, which occur in intertriginous areas. Pyostomatous vegetans, which involve the mucous membranes. Sweet syndrome, neutrophilic dermatosis, and metastatic Crohn is it's a rare disorder defined by cutaneous granuloma formation. Serious effects up to 10% of the patient with disorder and related to the bowel activity consistent with the potential shared immunogenetic basis of the disease. Rheumatological presentation can be in the form of peripheral arthritis, which developed in up to 20% with a patient with inflammatory bowel disease, is more common in Crohn and worsens with exacerbation of the bowel activity. It's asymmetric, polyarticular, and migratory, and most often affects large joints of the upper and lower extremities. Treatment is directed at reducing bowel inflammation. In severe ulcerative colitis, colectomy frequently cures the arthritis. Ankylosing spondylitis occurs about 10% of the patients with inflammatory bowel disease and more common in Crohn. About 2/3 of the patients with ankylosing spondylitis expresses HLA-B27 antigen, human leukocytes antigen B27. The activity of ankylosing spondylitis is not related to bowel activity and does not remit the glucocorticosteroids or colectomy. It most often affects the spine and pelvis, producing symptoms of diffuse low back pain, buttocks pain, and morning stiffness. The course of continuous and progressive, leading to permanent skeletal damage and deformity. Anti-tumor necrosis factor therapy reduces spinal inflammation and improves function, status, and quality of life. Sacroiliitics is symmetric, occurs equally in ulcerative and chronic, and often asymptomatic. Does not correlate with the bowel activity and does not always progress to ankylosing spondylitis. Other rheumatic manifestations include hypertrophic osteopathy, femoral osteomyelitis, and relapsing polychondritis. Hepatobiliary presentation can be in form of hepatic steatosis, which is detectable in about 1/2 of the abdominal liver biopsies from patients with chronic ulcerative. Patient usually presents with hepatomegaly. Fatty liver usually results from a combination of chronic debilitating illness, malnutrition, and glucocorticoid therapy. Cholelithiasis occurs in up to 10 to 35 patients of Crohn's disease with ileitis or ileal resection. Gallstone formation is caused by malabsorption of the bile acids, resulting in depletion of the bile salt pool and the secretion of lithogenic bile. Primary sclerosing cholangitis is a disorder characterized by both intrahepatic and extrahepatic bile duct inflammation and fibrosis, frequently leading to biliary cirrhosis and hepatic failure. Most patients have no symptoms at the time of diagnosis. When symptoms are present, they consist of fatigue, jaundice, abdominal pain, fever, anorexia, and malaise. The traditional gold standard diagnostic test is endoscopic retrograde cholangiopancreatography. Gallbladder polyps in patients with psoriasis have a high incidence of malignancy, and cholecystectomy is recommended, even if mass lesion is less than 1 centimeter in diameter. Gallbladder surveillance with ultrasound should be performed annually, especially in the presence of primary sclerosing cholangitis. Endoscopic stenting may be palliative for cholestasis secondary to bile duct obstruction. The incidence of ocular complication of inflammatory bowel disease patient is up to 10%. The most common are conjunctivitis, anterior-uveitis uveitis, and episcleritis. Uveitis is associated both with ulcerative and chronic. Colitis may be found during periods of remission and may develop in patients following bowel resection. Symptoms include ocular pain, photophobia, blurred vision, or headache. The most frequent genitourinary complications are calculi, urethral obstruction, and ileal bladder fistula. The highest frequency of nephrolithiasis occurs in patients with chronic following small bowel resection. Calcium oxalate stone develops secondary to hyperoxaluria, which results from increased absorption of dietary oxalate. Low bone mass occurs up to 42% of patients with inflammatory bowel disease. The risk is increased by glucocorticosteroids, METHOTREXATE, and total parenteral nutrition. Malabsorption and inflammation mediated by interleukins 1/6, tumor necrosis factor alpha, and other inflammatory mediators also contribute to low bone density. Treatment of inflammatory bowel disease is made on the basis of the disease site, pattern, activity, and severity. The general goals of the treatment are the following: to achieve the best possible clinical, laboratory, and histologic control of the inflammatory bowel disease with the least adverse effects from medication, to permit the patient to function as normal as possible, in children to promote growth with adequate nutrition. For treatment, we're using several types of the drugs, and the start of the therapy, as we named, will depend from the disease site, pattern activity, and actually severity. So aminoacylates are effective at inducing and maintaining remission of ulcerative colitis. They may have a limited role in inducing remission of the Crohn, but no clear role in maintenance of the Crohn. New sulfur-free aminoacylate preparation deliver increased amounts of pharmacologically active ingredient of sulfasalazine to the site of active bowel disease while limiting systemic toxicity. There are four main aminoacylated acid drugs, but usually we used only three. One is balsalazide, mesalamine, or sulfasalazine. Aminoacylates can reduce leukotriene production, can inhibit the cellular release of interleukin-1, all of which are likely to be important in reducing the acute inflammatory response in inflammatory bowel disease. The aminoacylates may maintain remission in inflammatory bowel disease by preventing leukocyte recruitment into the bowel wall. The drugs that inhibit the chemotactic response of leukotriene before, reduce the synthesis of platelet-activating factor, and also inhibit leukocyte adhesion molecular upregulation. The majority of the patients with moderate to severe ulcerative colitis benefit from oral or parenteral glucocorticosteroids. Prednisone is usually started at doses 40 to 60 mg by day for active ulcerative colitis that is unresponsive to salicylate therapy. Parenteral glucocorticosteroids may be administered as hydrocortisone or methylprednisolone. A new glucocorticosteroid for ulcerative colitis, budesonide, is released entirely in the colon and has minimal 2-glucocorticoid side effects. The dose is 9 mg by day for 8 weeks and no taper is required. Topically applied glucocorticoids are also beneficial in distal colitis and may serve as an adjunct in those who have rectal involvement, plus more proximal disease. Higher cortisone enemas or form may control active disease, although they have no prominent role as maintenance therapy. These glucocorticoids are significantly absorbed from the rectum and can lead to adrenal suppression with prolonged administration. Topical salicylate therapy is more effective than topical steroidal therapy in treatment of the distal ulcerative colitis. A short course of corticosteroid therapy is indicated in patients with severe systemic symptoms and in those whose condition does not respond to any anti-inflammatory agents. Steroids are not indicated for maintenance because of serious complications such as aseptic necrosis of hip, osteoporosis, diabetes, and hypertension, and others. Accordingly, once remission is achieved, the agents are slowly tapered. It should be noted that steroids do not modify disease or induce sustained mucosal healing. Antibiotics have no role in the treatment of acute or cushioned ulcerative colitis. However, pouchitis, which occurs about up to 50% of cases of ulceration after colectomy, and usually responds to treatment with metronidazole and or ciprofloxacin. Metronidazole is effective in active inflammatory fistulae, xanthine, and perianal Crohn and may prevent recurrence after ileal resection. The most effective dose is 15-20 mg kilogram by kilogram per day in 3 divided doses. It's usually continued for several months. Common side effects include nausea, metallic taste, and disulfiram-like reaction. Peripheral neuropathy can occur with prolonged administration and on rare occasions is permanent despite discontinuation. Ciprofloxacin in dosage of 500 mg twice a day is also beneficial for inflammatory perianal and fistulizing Crohn, but has been associated with tendinitis and tendon rupture. Both ciprofloxacin and metronidazole antibiotics can be used only for a short period of time due to side effects. Azathiopryne and 6-mercaptopurine are purine analogs used concomitantly with absorbed and converted to with biological therapy or less often as the sole immunosuppressant. Azathioprine is rapidly absorbed and converted to mercaptopurine, which is then metabolized to the active end product, tioisogenic acid, an inhibitor of purine ribonucleotide synthesis and cell proliferation. The doses used to range from 2 to 3 milligrams by kilo per day for azathioprine and 1 to 1.5 milligram by kilo per day for mercaptopurine. Also, azathioprine and mercaptopurine are usually well tolerated. Pancreatitis occurs in up to 4% of the patients, typically present within the first few weeks of the therapy. It's completely reversible when the drug is stopped. Other side effects include nausea, fever, rash, and hepatitis. Bone marrow suppression, particularly leukopenia, is dose-related and often delayed, necessitating regular monitoring of the complete blood count. Methotrexate inhibits dehydrofolate reductase, resulting in impaired DNA synthesis. Additional anti-inflammatory properties may be related to decrease in the production of interleukin-1. It's used most often concomitantly with biological therapy to decrease antibody formation and improve disease response. Intramuscular or subcutaneous doses ranges from 15 to 25 milligrams per week. Potential toxicities include leukopenia and hepatic fibrosis, necessitating periodic evaluation of CBC and liver enzymes. Cyclosphorin is a lipophilic peptide with inhibitory effects on both the cellular and humoral immune system. It blocks the production of interleukin-2 by T helper lymphocytes. Cyclosphorin binds the cyclophilin and its complex inhibits calcineurin, a cytoplasmatic phosphatase enzyme involved in the activation of T cells. This drug is also indirectly inhibits T cells function by blocking helper T cells. Has a more rapid onset of action than mercaptopurine and azathioprine. Cyclosphorin is most effective when given a dosage to 2 to 4 milligrams per kilogram per day intravenously in severe ulcerative colitis that is refractory to intravenous glucocorticosteroids, and 82 patients showing response. Can be an alternative to conectomy. May cause significant toxicity. Renal function should be monitored frequently. Hypertension, gingival hyperplasia, hypertrichosis, paresthesis, tremors, headaches, and electrolyte abnormalities are common side effects. Creatinine evaluation calls dose reduction or discontinuation. Seizures may also complicate therapy, especially if the patient is hypomagnesemia or if serum cholesterol levels less than 3.1 millimole by liter. Opportunistic infection, most notably pneumocystis pneumonia, may occur with combination immunosuppressive treatment. Prophylaxis should be given. Biological therapy is now commonly given as an essential therapy and initial therapy for patients with moderate to severe Crohn or ulcerative. Patients who respond to biologic therapies enjoy an improvement in clinical symptoms, a better quality of life, less disability, fatigue, and depression, and fewer surgeries and hospitalization. But this therapy is still expensive compared with the previously noted. So there are at least 3 drug classes now possible to use. It's anti-tumor necrosis alpha agents, anti-integrin, and anti-interleukin 12 or 23 preparation presented on this actually table. Tumor necrosis factor, a key inflammatory cytokine and mediator of intestinal, and not only intestinal, but inflammation, is expressed prominently in inflammatory bowel disease. Patients likely to benefit from anti-tumor necrosis factor therapy include the following. Patients who are having moderate to severe debilitating symptoms of Crohn, who have documented active inflammation, or who are dependent on corticosteroid and unable to taper these agents without return of the symptoms. Patients who do not show evidence of active bowel infection as cause of GI symptoms. Before administering these drugs, clinicians should screen patients for mycobacterium tuberculosis. In addition, caution is advised if patient has hepatitis B virus carrier. As tumor necrosis factor is pro-inflammatory cytokine, blockage of these factors lead to reactivation of tuberculosis, decreasing of phagocytosis, appear a high risk of different infectious diseases, including respiratory and urinary infections, and appearance of autoimmune antibodies and lupus-like syndrome, plus elevation in liver enzymes. Patients should be full despite this therapy gives patient the possibility to at least not decrease symptoms and gain the better quality of life. Serious adverse events doctors should remember about serious adverse event and follow up patient. Integrins are expressed on the cell surface of leukocytes and serve as mediators of leukocyte adhesion to vascular endothelium. Integrin along with its alpha-4, integrin along with its beta-1 and beta-7 subunit interact with endothelial ligands termed adhesion molecules. Interaction between alpha-4, B7 and mucosal adenosine cellular adhesion molecule is important in lymphocyte traffic into gut mucosa. Natalizumab is a recombinant humanized immunoglobulin antibody against alpha-4 integrin that has been shown to be effective in induction and maintenance of patients with Crohn's disease. This drug is no longer widely used due to risk of progressive multifocal leukoencephalopathy. Vedolizumab, another leukocyte trafficking inhibitor, is a monoclonal antibody directed against alpha-4 beta-7 integrin specifically and has the ability to convey gut-selective immunosuppression. It's indicated for Crohn's or ulcerative patients who have had an inadequate response or lost response to or were intolerant to tumor necrosis factor blocker or immunomodulator, or had an inadequate response or were intolerant to or demonstrated dependence on glucocorticosteroids. Ustekinumab, a fully human immunoglobulin 1 monoclonal antibody, blocks the biological activity of interleukin 12 and 23 through their common P4 T subunit by inhibiting the interaction of these cytokines with their receptors on T cells, natural killer cells, and antigen-presenting cells. It has recently been FDA approved for use of Crohn's patients who have failed or were intolerant to immunomodulator or corticosteroid therapy, but who never failed treatment with anti-tumor necrosis factor therapy, or who failed or were intolerant to treatment with one of or more anti-tumor necrosis factor medication. Diarrhea may develop as a result of active disease, and other possible causes include acute infection, bacterial overgrowth, loss of ileocecal valve, short bowel syndrome, lactase deficiency, concomitant celiac disease, and functional bowel syndrome. Chronic diarrhea in Crohn responds well to antidiarrheal agents such as loperamide, bile acid binders, difenoxylide with atropine, and tincture of opium. Such agents should be considered with care in active colitis because of the risk of toxic megacolon. Patients with terminal ileal disease or previous terminal ileal resection may not absorb bile acid normally, and this abnormality can lead to secretory diarrhea in the colon. This patient may benefit from bile acid sequestrants. Those who have extensive ileal disease or have undergone resection of more than 100 centimeters of the ileum have detectable defective bile salt absorption and develop steatorrhea. They benefit from a low-fat diet and medium-chain triglyceride preparation. Bile sequestrants exacerbate this type of diarrhea. Abdominal cramps may be reduced with antispasm agents such as propateline, dicyclomine, or hyoscyamine. However, the drug should be used if there is the possibility of the bowel obstruction. It should not be used. Surgical therapy. On the slide, you can see indication of the surgery for the patient with ulcerative Crohn's. Mostly it's in case of complication, presence of the strictures or obstruction or fistulization. In Crohn, appearance of the cancer or polyps in both. Nearly one half of the patients with extensive chronic ulcerative colitis undergo surgery within the 10 years of the illness. Because ulcerative colitis is a mucosal disease, the rectal mucosa can be dissected and removed down to the dentate line of the anus or about 2 centimeters proximal to this line. The ileum is fashioned into a porch that serves as new rectum. Most patients with Crohn require at least one operation in their lifetime. The need of surgery is related to duration of the disease and the site of involvement. Patients with small bowel disease have 80% chance of requiring surgery. Those with colitis alone have 50% of chance. Surgery is an option only when the medical treatment has failed or complications dictate its necessity. Ulcerative and Crohn have similar features to many other disorders. In the absence of a key diagnostic test, a combination of features is used. Once a diagnosis of inflammatory bowel disease is made, distinguishing between ulcerative and Crohn is possible initially in up to 15% of cases. These are termed indeterminate colitis. Fortunately, in most cases, the true nature of underlying colitis becomes evident later in the course of the patient disease. Tuberculosis is also in the differential diagnosis of the Crohn. Simple clinical findings appear to be most accurate for differentiated Crohn from intestinal tuberculosis. Anti-Saccharomyces cerevisiae antibodies do not have differentiated small bowel tuberculosis from small bowel Crohn disease. The rectum is always involved in ulcerative colitis, and this is primarily involves continuous lesions of the mucosa and submucosa. Both ulcerative and Crohn usually have waxing and waning density and severity. When the patient is symptomatic due to the active inflammation, the disease is considered to be an active stage. The patient is having a flare of inflammatory bowel disease. In many cases, symptoms correspond well to the degree of inflammation present in their disease. Surgical intervention for ulcerative colitis is curative for the colonic disease and potential colonic malignancy, but is not curative for the Crohn's. So, to notice the difference between Crohn and ulcerative, you mostly should remember that ulcerative is mostly superficial process concentrated on the colon, as Crohn is a disorder from mouth to anus and it's transmural. So if an ulcerative complication mostly presented with toxic megacolon or bleeding, in Crohn is present with abscesses, mostly fistulas, bleeding or obstruction of the bowel. Complications of inflammatory bowel disease can be associated intestinal and extraintestinal. Intestinal can be associated with several gastrointestinal complications, including risk of the hemorrhage, perforation, strictures, and fistulas, as well as perineal disease and related complications such as perineal or pelvic abscesses, toxic megacolon, complicated active tuberculosis, and malignancy. Extraintestinal complications occur in approximately up to 25% of patients. In some cases, they may be more symptomatic than the bowel disease itself. It includes osteoporosis, usually a consequence of prolonged corticosteroid use, hypercoagulability resulting in venous thromboembolism, anemia, gallstones, primary sclerosis and cholangitis, active ulcers, arthritis, uveitis or uveitis, and episcleritis, and skin complications we previously already named in this lecture. So thank you very much for your attention. If you do have any question, you can write exclusively on my email or put them under this presentation either on YouTube channel or Facebook page. Thank you and goodbye.